Yes? Okay. All right. So a little bit about me. I'm Jessica Benedict. I'm a women's health nurse practitioner. I've been in medicine for 20 years. Of those 20 years, I've been primarily focusing on menopause, perimenopause, hormone therapy. I've been in that kind of space for about 5 to 6 years now. It's really my passion. It's kind of how my practice has evolved. I started as in obstetrics, basically. I was a labor and delivery nurse, became a nurse practitioner, did obstetrics for the bulk of 10 years, and realized that as I was aging out of that kind of range, I wasn't able to connect with my patients anymore. So this was my platform to really understand. And then, oh, by the way, when I started my perimenopause journey, I sought some help from my provider, who looked at me like I had two heads, because we get very little training. We get about 2 to 4 weeks of training on average in med school for menopause, and that's about it. That's terrible. So I'm here to hopefully change that. But today is all about brain health and how hormones impact brain health and functioning. So show of hands in the room, who's had brain fog? Yeah, a little bit. 2 hands maybe. Yeah. Okay. Fabulous. All right. So let's talk timeline. Brain health kind of across the lifespan. So first and foremost, I want to point out, as you can see on the slide here at the top, we do want to hit on early dementia. It is rare, but it's an important topic to discuss. Early dementia is usually diagnosed between ages of 40 to 60s. It's often linked to genetic or autoimmune disorders, and can be vascular as well. Significant metabolic dysfunction is also a compounding factor. The reason I bring this up is because symptoms oftentimes overlap perimenopausal symptoms, so it can go unrecognized for quite some time. But again, it is rare, so I just want to point that out. So starting at the reproductive age, things are nice and stable. Our estrogen is doing what it's supposed to do. Our memories, hopefully, on board. Pregnancy brain is a real deal, though. I will attest to that. But our brain is using our energy effectively and doing what it should be doing. As we move into perimenopause, 40s to 50s, things start to shift. Hi, welcome in. Come on in. We have fluctuating estrogen. I'm going to let these fine folks get settled in. Sorry. No worries. Welcome in. All right, so we're just getting started. We're here talking about some brain health across the lifespan. So with perimenopause, we see that fluctuating estrogen level that impacts mood changes, sleep for sure, energy. There's that lovely brain fog that everyone says yes to. We do develop hot flashes, night sweats for a lot of people. This impacts sleep even further, which further impacts brain health. You can see how this snowball starts to happen. As we move into menopause, we see that the estrogen declining shifts how our brain is actually doing its job, metabolizing what it's supposed to be, which is usually glucose, right? It's also determining how our thermoregulation system is functioning, and it's kind of haywire at that point because things are so out of whack. So there's a lot of increase for vulnerability, depression, insomnia, cardiovascular issues. All of these changes happen in this space of time. So it's a very short period of time if you look at the general lifespan, but big changes are happening. With early menopause, I should back up 1 second here. Early menopause is defined anytime that happens before the age of 45 or surgical menopause. Surgical menopause is when we remove your ovaries, very different beast. Usually those symptoms come on hard and fast because we force your body into menopause as opposed to a kind of a steady decline that we see. Moving into midlife, we see more of these cardiometabolic risk factors start to really play a big factor in this. High blood pressure, diabetes, obesity, all of these become big drivers for cognitive decline and functioning. Lifestyle factors also continue to play a part. We don't exercise the way that we do in our 20s when we're, in our 50s and 60s, and we're not perhaps sleeping as robustly as we used to, and our social connections might not be as strong. So that is something that we'll talk about later on for sure. With later on in life, Of course, age is always that number one kind of risk factor for cognitive decline. And clearly, as we get older, things do start to decline. And there's also that accumulation of those vascular and metabolic disorders that compound things as that continues. And we always stress sleep hygiene, but we stress it even more later on in life. So, why do hormones matter? And this is a big kind of slide here, if you will. And in particular, estrogen makes the biggest difference because it plays that critical role in optimizing how your brain is functioning. How is it being that powerful neuroprotectant, meaning it's really benefiting the brain itself in cognitive health. It promotes those neural survivals. So when we talk kind of neurons and synapses and all of this, I kind of think of it like the game of telephone. Who's played telephone in here before, right? We all know that. Yeah. Okay. So if I'm to whisper something to Courtney, there's a space between us, right? And if it's nice and close, she's going to be able to hear me. But if I'm whispering from here to Courtney, who's sitting well arm's length out of reach, she might not hear me. So that's not really, that connection's not always going to be there, right? Well, estrogen will help with that connection, will help that message get received, where as we age, those gaps actually start to lengthen. And so we see this and we know that as your estrogen levels decline, that gap is getting wider. So it does take longer to find that word. Find, why did I walk into this room? Why did I open the refrigerator? We've all been there. Why did I put the milk back in the cabinet and not in the refrigerator? I've done that more than once, unfortunately. And then furthermore, it helps with blood flow and glucose metabolism. So the brain really uses glucose as kind of its fuel. Well, the issue is as estrogen starts to decline in the brain, it switches from using glucose to using ketones, which is from fat metabolism. And that switch can be very disruptive. So we do oftentimes see like, God, why is my brain fog so much worse now that I'm kind of going through this? Sure, I had it when I was having a newborn and all of that. Sure, sleep deprived, absolutely. But why is it so significant at this point in time? And it's because of that switch. Once that switch happens, the brain actually becomes a little more effective at adapting to utilizing the ketones appropriately, but it's still not as robust as when it was using that glucose, for sure. It also helps directly influence certain neurotransmitters. So your happy chemicals in the brain, right? Your serotonin, your dopamine, which helps with mood regulation and memory, which is acetylcholine. So it helps with all of these things. So one of the things that I always get a question on, without reading it, if you can. Does anyone know what menopause is truly defined as? Yes, ma'am. Yeah, I hope so too. All right.
Not having your period for 12 months.
Bingo. Yes, exactly. And people used to, we've always kind of been under the impression, the general population assumes menopause is this thing that happens after that period stops, right? It's actually just the definition of that line in the sand that's been drawn. So we are perimenopause. Menopause is, okay, things have stopped, and now we're postmenopausal. Does that make sense? And just because I like to, make things a little bit muddier, if you will, perimenopause is actually defined as the symptoms or menstrual cycle changes tend to be the first thing that happens, plus other menopause-related symptoms, which I'll cover, that extend past that line in the sand for 1 year after that. So perimenopause are the years leading up to the line in the sand, plus the year after that. So it's a little bit different. There's actually more stages to it, but I won't get into that because it gets very confusing. All right. So I know. Yep. Take it in for a second. Common perimenopause, menopausal symptoms. I'll start with each box and we'll move through it slowly. Menstrual cycle changes are usually the first factor, meaning patients come in and are like, yeah, my cycles are suddenly shorter. They might be heavier in flow sometimes, lighter in flow other times, but they're kind of erratic at times. They might still be regular. I have patients that every so often they're like, yeah, I had one really big period and then that was it. Usually it's more, gosh, I had 2 periods this month. And then I go 4 months without a period. And I'll have another period. And then it's kind of regular for a little while. And then it's back to a couple of months here and there. That's not uncommon, which, by the way, we do have a Tuesday talk coming up. Is it next month? Yep. On abnormal bleeding, what's normal, what's not normal. So for those on Zoom, if you're interested, please attend. Okay. Breast tenderness is also on there, painful cramps. These are all really common things. Now, does this mean it's common as in you shouldn't be talking to your provider? No, not at all. Because any changes to menstrual cycles, we should be aware of that. So we can help guide you. Is this really normal or is there more to this that we need to be investigating? So I don't want to just sleep on that and say, oh yeah, this is a normal, common thing. It might not always be normal or common. Vasomotor symptoms. Vasomotor symptoms are those thermoregulation changes. So hot flashes, night sweats. I wake up in a pool of my own sweat. It's fabulous. I have to go shower, change my sheets, or I sleep on towels now. My husband's always on 4 blankets and I've got none on and the fan's on. Yeah, we know how that goes, right? And then you're suddenly freezing cold because that hot flash has ended and now you're left with just a puddly mess and it's not super fun. So I can help with all of that, but that is definitely a component. Some people will say, I don't really have a hot flash, but I just feel like somebody has turned on that internal temperature. I just feel hot all the time. That's also a vasomotor symptom that can happen. Sleep disruption. Why? Because you're waking up in the middle of the night. You're having to change your bedding. You're having to change your clothes. Anxiety also comes along with that. We see that quite often where, oh my gosh, I get really hot and now I'm super anxious. And it's like this perpetual hamster wheel that we get stuck in. Other symptoms or changes, again, sleep disruption, mood swings, irritability, anxiety, low libido is huge, huge, huge. I don't think we spend enough time on it in women's health to really understand the dynamic of what a low libido truly looks like for females as we age, which is unfortunate because I think that's a massive component. Painful sex, urinary changes. That's why we're all here sitting in this lovely clinic. Joint pains, muscle aches. My lovely random symptom was I had itchy ears, like internal itchy ears. Like I could grab a Q-tip and want to dig in because it was just driving me crazy. I don't have that anymore because I have my hormones. So fatigue, heart palpitations, these are also all really normal. Dry skin, hair changes. I get it constantly, my hair is constantly falling out or it feels thin or brittle and it just seems to be breaking all the time. Again, it absolutely can be perimenopause or menopause, but one of the things is that you're having this conversation with either myself, Dr. Bonilo, because it might not be normal. It could be a thyroid disorder. It could be a low ferritin. It could be a low vitamin D level. So if you're seeing somebody who is not me for hormones, you need to be asking these questions. Like, are you going to be screening me for these things? Because this is part of my normal. This is what I look at and make sure there's nothing else kind of underlying that could be contributing to these things. And then, of course, last but not least is cognitive changes. Brain fog, difficulty concentrating, slower word recall. I always love these presentations because sometimes I forget my words. So I have my cheat sheets in front of me just in case. Mental fatigue, that's a huge one. I don't know about you guys, but I feel like when I get home at night, if I've had a really, taxing day, it's gone. Like don't ask me to solve 2 + 2. It's not going to happen. Might not happen on a good day regardless, but it's not going to happen, okay? Trouble staying focused is another big one. I don't know about you guys, but I feel like a lot of what I'm hearing is, oh, I might have adult ADD or ADHD. Might not be that. It could just be the fact that your hormones are all kind of crazy and out of whack right now. Who knows? Okay. Oh, and fun fact, 2 out of 3 women will have brain fog. That's how common it is. We're great at multitasking. We might not remember why we're multitasking, but we're great at it. So there's that. All right. So brain health and hormone changes. There's a lot on here, I know. So estrogen and memory support. I'm going to hammer this home. The brain loves its estrogen. Estrogen helps keep that memory center, really the hippocampus, really focused and doing what it needs to do. During perimenopause, again, those shifting hormone levels are going to cause things to not be as reactive, right? So again, you're going to go into the refrigerator and why did I get here? For brain energy and shift during menopause, we see that as estrogen falls, again, that brain steadily changes from glucose metabolism over to ketone metabolism to use that as fuel. With sleep disruption and cognitive load, that is a huge deal. I don't know if you guys have ever had a really terrible, or actually I should ask you guys, who has had a really terrible night where they can't sleep and then the next day they feel like they're functioning on all cylinders? If you raise your hand, I'm going to be very impressed. Yeah, I didn't think so. Yeah, because if you're not sleeping well, you're not going to function well. So poor sleep, major driver, big time driver. For hormone replacement therapy and neuroprotection, this is where we're going to start to really dig in, because I get this a lot. Well, I'm not having a lot of symptoms, but I really want it for brain health. You know, my mom and dad, they had Alzheimer's or dementia, or my great aunt had it and I watched her kind of suffer. I want you to be aware that starting hormone replacement therapy, and again, we're going to get into this, can be somewhat helpful in stabilizing those estrogen levels, but ultimately we're not using it for prevention. And timing really does matter when you start those hormones. So, cognitive decline and dementia. What are some risk factors and what are some preventative measures? Risk factors, age is the number one. As we age, it's just inevitable, and there's not much aside from what is on the preventative list here that we can be doing. Early menopause or surgical menopause increases that risk exponentially, and then especially if they're not on hormone replacement therapy. Any high blood pressure that's uncontrolled, diabetes that's uncontrolled, or even high cholesterol that's uncontrolled makes a huge difference. So working with primary care, making sure that you're kind of dialed in on your general health is always the recommendation. For obesity in particular, it tends to be that truncal or central obesity, which I have my own theory on that for the record, because I constantly get people coming in and they're like, oh, I can't wait to go on hormones because it's going to really help me lose weight. It doesn't help you lose weight, unfortunately. I wish it does. In theory, it would make sense. We're giving you back this hormone, your metabolic rate should suddenly, okay, we're back in our 20s. Not the case. So it's an issue. What my theory is I think Mother Nature's designed us to kind of hold on to some fat cells, because we know that fat cells create their own form of estrogen and protective. So I think Mother Nature's like, cool, we're just going to have you gain some weight and we're going to have you hang on to it, just for protection purposes. I want like a list that's like, Mother Nature, I'd like to put it in this part of my body and not this part of my body. Please and thank you. Right? Depression also plays a big factor in cognitive decline. We see this. We know that patients who have untreated depression, medication, therapy, whatever that might look like, we know that if it goes untreated, it can make a big difference. Physical inactivity. If you are not staying physically active, we're going to see that brain health go down. And we know this because we can actually study how the brain looks, not only with like an MRI and imaging and all of that, but we actually can look at the surface of the brain and see how the little rugation or the crevices, the folds, thank you, in the brain, that actually starts to smooth out in patients that aren't as physically active. Also in patients who have dementia. So there's that. Poor sleep, again, I've hit the nail on the head with this. I won't keep kind of berating you on it. Hearing loss is also a component. There's some neuro aspect to it, but I think also if you're not going to be able to hear me, you're not going to really want to, really interact and have those brain building activities that happen. Smoking and heavy alcohol use. So similar to physical inactivity, we see that those folds and valleys and crevices in the brain actually start to smooth out in somebody who smokes heavily or uses alcohol heavily, especially the alcohol component. Social isolation, and then any pregnancy complications. High blood pressure tends to be the biggest one. The way that I think about it in terms of preeclampsia or high blood pressure in pregnancy is when you're pregnant, your vessels basically dilate to accommodate the extra blood volume that you have during pregnancy. And with preeclampsia, what happens is, if you think about it, your garden hose has now turned into a fire hose. Okay. And with preeclampsia, that fire hose decreases back down to a garden hose size, but you still have that same pressure. You still have that same blood volume. So you have increased pressure on those vessels. Does that make sense? So that's where it starts impacting the brain health. And that can be long term if it's not well treated in pregnancy. And then of course, traumatic brain injury is a component as well. For prevention, monitoring that blood pressure, especially in midlife, is huge. So if you come and see me for an annual exam, one of the first things you will do every single year you see me is you're going to have a blood pressure check. And I'm going to tell you, if it's too high, you're going to go see your primary care provider, because that's how we do things. Okay. Staying physically active, also super important. Prioritizing that sleep quality, treating any hearing loss. So by the way, Costco does hearing tests, and I think they're actually free. You can go get it tested if you're oh so curious. I'm going to send my husband over there. It's true. That is selective. Yeah, that is selective. You're right. I'm still going to send him. I think he is deaf, but still. Maintaining a healthy weight, controlling any diabetes and cholesterol issues, which we've touched on. Of course, avoiding smoking, limiting alcohol. By the way, studies keep going back and forth. Some studies say, oh, a glass of wine a night is totally fine and has protective benefits. And then other studies are like, absolutely not. No alcohol is considered healthy. I'm not going to weigh in on one study or another, but I will say that I don't think alcohol is the best choice, especially if you're having night sweats and hot flashes, because that's only going to compound that drastically. Staying socially connected, of course. I always say, go for a walk, grab a buddy, have a conversation, not your spouse, somebody else, right? Manage any depression or chronic stress. That's a huge one. Making sure that we stay in tune with cognitive activities. So word puzzles, crosswords, Sudoku, the number game, anything that's going to keep your brain kind of sharp. That's always the recommendation. I'm sure there's tons of apps and games out there now that basically do that. Following a brain healthy diet, Mediterranean diet. Anyone? Yeah? Fabulous. Awesome. Trying, yeah. I feel like it's a fairly easy diet to follow. It's not super restrictive. It's a lot of fish and healthy fats and healthy grains, that kind of thing. I don't think it's particularly difficult to stick to, but it does take a little retraining if you've been more on the McDonald's route. So. And then use of hormone replacement therapy or HRT when appropriate, especially for those early menopause or surgically menopaused folks. So that's kind of how we can help with that. And the next slide talks a little bit more about some of the data, kind of what are the current recommendations. So first and foremost, HRT or hormone replacement therapy is not recommended, again, for the prevention of dementia. And we actually did have a recent systematic review and meta-analysis just this year that looked even further and found that HRT really does not protect against dementia. I wish it did, but it just doesn't. So again, if a patient comes in and they're like, hey, I really want it just for preventative sake, we're gonna have a bigger conversation about what are some other lifestyle modifications that we can be doing to really help. Again, timing is key. So I know up here it says timing matters under one of those. I'm going to just keep saying timing is key because it really is key. And I'll give you a couple analogies as why that is a big deal. But first and foremost, hormone replacement therapy, Should be based on symptoms. Again, not just for preventative measures. I could talk all day on all of the benefits of hormone replacement therapy, bone health, brain health, breast health, you name it. Absolutely. There are benefits, but unfortunately, we don't have the data to say, yes, this is the smoking gun. Everybody should be on it. Interestingly enough, combined estrogen and progesterone. So when we talk hormone replacement therapy, if you have a uterus still, you need both estrogen and progesterone. Because if we just give you estrogen alone, your uterine lining, which used to be sloughed off during your menstrual cycle, could start to regrow and in rare cases can become cancerous. So we need to avoid that, obviously. So we use both estrogen and progesterone. But the interesting part here is one of the studies, and this was the Women's Health Initiative study, but again, we looked at the data recently, and what they found was estrogen alone has a slightly lower risk of dementia, but adding in progesterone sometimes can increase the risk of dementia. The only caveat to that is if you have a hormone provider who's giving you hormones, most of us use bioidentical micronized progesterone at this point. The bulk of what we discovered was it was a lot of the synthetic progesterones that were being used that was increasing the risk of dementia and Alzheimer's. And it really also makes a difference if you have higher risk factors. So if you're over the age of 70, if you're a carrier for a gene mutation, and in Caucasian women, we just tend to have higher risk of this happening. So again, estrogen alone therapy might carry a slightly lower dementia risk than combined therapy. But again, it really comes down to any markers, increased risk factors, and are we using bioidentical hormones? So going back to that, timing matters. So this is where it is key, because we like to start any form of hormone replacement therapy within 10 years of the onset of menopause, which again is that line drawn in the sand of 12 months without a period. If you don't have a uterus and we're looking at, a hysterectomy kind of scenario, and you're like, I don't know when I went through menopause, your provider can actually order some blood work to see, are you menopausal, are you not menopausal, and then determine what the best course of action is there. But we want to be introducing it before that 10-year mark or before the age of 60, 65. There's kind of conflicting endpoints, but usually within the 10-year mark. The reason for this is it seems pointless to put on a bicycle helmet when you're already on your bike pedaling and you've fallen off of it twice. Does that ring a bell, right? Like, it doesn't make sense to put on a helmet at that point. You already fell down, maybe hit your head. So we got to put the helmet on before we do that, right? The other component is that it's a rusty engine. So I mentioned the glucose, right? Your brain is using glucose to function. Well, then it switches to ketones. If I give a 70-year-old estrogen, I'm now telling her brain it's perfectly acceptable to leave those ketones alone and let's start using that glucose again. Well, guess what? Her system has completely rearranged so that it's only primarily functioning off of those ketones. So now if I basically try to rearrange things again, things are going to get really haywire. And now that we're older, that is going to be a much harder shift. So we don't want to be doing that. Aside from the fact that it can also increase the stress load on those cells in the brain that are doing that job, and it can lead to damage to them. So we really want to avoid that. So ultimately, that combined estrogen progesterone absolutely can increase the dementia risk, especially when we're not factoring in that timing. We want to be doing it within that 10-year window. So what do we know? Not recommended for prevention. Starting late after menopause can actually increase the risk of dementia. Excuse me. Combined estrogen progesterone also shows a higher dementia risk in certain women. Estrogen only, a little bit less risk. But again, if you have a uterus, nope, we got to add in that progesterone. Hormone replacement therapy can help improve sleep and those vasomotor symptoms, which automatically can help with brain and cognitive functioning, which is great. And then research is really inconsistent. I wish I had better news, but it is really inconsistent. So what do we not know at this point? We know that HRT dose route, we're not sure. We're not sure which dose or route or lotion or potion makes a difference when it comes to dementia risk. The jury's completely out on that. The exact critical kind of window or timing, still undetermined. That's also duration of how long you should be on hormones. I get this question all the time. Well, once I start hormones, do I just stay on them or do I have to come off of them? The old school train of thought was after 5 years, you should wean off of it. Well, there would be a lot of murderous, raging women out there who would say otherwise. So we changed that and went, okay, 10 years. And then the same thing was kind of happening. So basically the experts have kind of taken a step back and gone, we don't have long enough studies to know, is there a true stopping point that we should be going, okay, everyone should be weaning off of this at this point. So that's a conversation for you and your provider to make sure, you haven't developed any risk factors to maybe think long and hard about weaning off of those hormones. Any woman who is more vulnerable, whether it be, a genetic biomarker, family history, whatnot, we don't know what that kind of looks like. Whether estrogen only therapy, again, is neutral, slightly protective in some groups. We know this, we can see this, but again, we don't have those big studies to really lean on. Again, how short-term cognitive relief affects long-term brain health, we don't know. We just don't have those studies. And true lifespan of HRT, again, not sure. Timing is everything. And then there's future hormone approaches, selective estrogen receptor modulators, neuroselective estrogens could perhaps support brain aging, but again, we just don't have those studies to say. So here's the lovely wrap it up. HRT should not be used as prevention. No evidence saying that starting HRT in menopause protects cognition. Combined therapy might actually increase in older women, especially again, that timing. If you got to catch that bus appropriately, because if the bus is already halfway down the road, you're not going to catch it at that point. Estrogen only, again, has less associated dementia risk. Hormones should only be prescribed for menopausal symptomatic relief and not for brain protection. And then women with higher biomarkers were more vulnerable for those risks, especially with that combined hormone replacement therapy. And the FDA is reevaluating dementia-related warnings, but it's still basically emphasizing a working relationship with your provider to make sure that the risk-benefit assessment is in favor of staying on hormones versus not. So, awesome. Questions?
Can I come up with you?
Yes.
It was important for us to provide gold standard care because that's what we do at Femme Flôr. And so Jessica took it upon herself to really go and pursue that certification. And it was a really hard exam. And I looked at your questions one day. I don't think you knew that I took a sneak, and I was like, what are they asking me?
It is. It's very challenging.
We are currently in a society that wants you to consume. They want you to purchase. They want you to put the fear of God in you so that you sign up and you pay all your retirement money for some wonder drug. So if you find yourself in front of a provider that is offering you hormone replacement therapy, go onto the Menopause Society website and see if they are listed as a certified provider. A lot of my colleagues are going to get upset with me, but the fact is that we only got 2 weeks of training in menopause as a resident, and that was back in 2014.
Yeah,
when I was there. We were still in the midst of the Women's Healthcare Initiative, right? Yeah. So the only training I got was whatever you do, don't buckle, don't give them those hormones, whatever you do. Okay, so we don't get good training. And so I just wanted to first say that very clear. I've had a lot of women come in. They're coming to see me for fairly unrelated issues. And after talking with them, I realized that they're not in the best care. They're not in the best care. So that's the homework. Make sure you look them up and and know that they've done their due diligence in understanding what they're providing for you. I wanted to talk a little bit about the WHI study
Mhm.
and what, like, where we are right now in terms of that study. So I think it was about 24 to 26 years ago, this study was started and stopped midway because they felt that the combination of hormones was causing too much breast cancer and other complications. And so they actually cut the study short, and they went to social media back then, right? Before going to the researchers and saying, oh my gosh, look what we found.
Mhm.
Cat was out of the bag. And within, I think I wasn't a full physician at the time, but within a very short period of time, they were snatching medication out of people's hands, right? And so the study was very well intended, but what has since happened is we have this 20-year gap of women who fall out of that window of being able to pursue these beneficial medications due to misinformation. And so I'd say probably 2 to 3 years ago, that study was blown wide open, and we finally said, we have reviewed this data like 20 times. We as a medical society can now say that it was flawed. The information was never verified, and there is a safe and beneficial way to return to this medication or to provide these medications. And so that's where we are. And so it's a trend. Everyone's excited about it, and we all want to be on the medication to make sure we're not that we're pursuing it while we're in that safety window. So again, take caution, educate yourself. If you're signed on, then you're doing the best that you can to safeguard yourself, but still pursue something that has been shown multiple times to be helpful in quality of life, which in my business, that does mean longer life, right? So I wanted to, the reason why I'm also saying that is that those long studies will come. We will get data. We will learn, what are the safe progesterones? What are the safe estradiols versus estriol versus, conjugated estrogen that we get from pregnant horses, right?
Yes.
What are the safe things, and what are the things that we should never revisit ever? So those studies are definitely ongoing. So really stay tuned. You never know what is going to be discovered over time. I think that's kind of the excitement of new medicine, is just kind of proceeding with caution, but with intrigue.
Yeah.
Talk a little bit about, can you go back in your slides because I can't remember.
Yeah.
Touched on that. Okay, so right now we really want to be careful in saying it's preventative for dementia. So how do we draw that connection between it's not preventative to it's keeping that connection between nerves, neurons short? How do we?
I would say definitely timing. I think timing is the biggest component. Is if we're looking at hormone replacement therapy, if we're going to introduce that, again, that timing is key. It's paramount. So for instance, I have a patient who has premature ovarian failure. She's 26 years old. One of the first things they did when they discovered that she had this at 23 years old is they put her on hormone replacement therapy instantly, because we know that with timing, her trajectory looks very different than, say, my trajectory, your trajectory might look. So the timing is key with that. If you are not somebody in that window where you can have hormones in a safe manner, in that timing, that ship has sailed, then we're looking at some of the other recommendations. Going for a walk with a buddy, doing your word cross puzzles or puzzles in general, something that's going to keep your brain sharp. To your point, there's lots of supplements out there that say they help with brain health. I don't think there's enough research on those yet to say if they're really beneficial or not. I love the functional medicine space. I love naturopathic medicine space. I think there's a time and a place for it, but there's also a time and a place for me to say, hey, this supplement might help. It might not help, right? And I don't want my patients to spend all this money on a supplement that ultimately might not help. So the tried and true, maintaining a healthy lifestyle, making sure that those, what we call comorbidities, if you have high blood pressure, high cholesterol, or high diabetes, making sure those are really buckled in and you've got a tight window on those so we can help you just overall improve general health. for sure.
What are some typical labs that one can expect?
Yeah.
Of the spectrum.
Yes, yes,
No
yes.
labs, too many labs.
Oh gosh, I know. Yeah. I mean, so first and foremost, if I'm going to be putting somebody on hormones, if I know that they've completed their menopause transition, so I don't need to confirm if they're menopausal or not, I will check your cholesterol panel if that's not been done within a reasonable amount of time, usually within a year, typically. I check a thyroid stimulating hormone. And oh, by the way, if you have family history of thyroid disorders, or you've got other sort of odd symptoms that might be thyroid related, I could do a very inclusive thyroid panel, really looking at not just the thyroid stimulating hormone, kind of what is your thyroid doing, but also looking at your circulating thyroid hormones and antibodies to make sure that your body's not trying to fight your thyroid. I check a ferritin level. I check a vitamin D level, because I want to make sure. There's really good research out there to say that if you are deficient in your iron stores and you're deficient in your vitamin D, your brain is not going to be functioning. And oh, by the way, your irritability and your anxiety is going to go through the roof. It's going to. So I'm going to make sure that those things all look normal. In certain cases, oh, go ahead.
What about if your ferritin level is so high?
Yeah, so that's a tough one. If your ferritin level is high, you're going to be working with either your primary or a hematologist to figure out how to bring those stores into a normal range, because that can also be disruptive. For sure. Great question. Yeah, I know. Yeah. So going back to some other labs. So if I have a patient who's really data driven, somebody who's like, I just want to know where I'm going to get, right? Because I can look at your estrogen level once you're on hormone replacement therapy to make sure that it's in the optimal range. Do I always start with a baseline? No, because for most of my postmenopausal women, I can tell you what your level is going to be. It's going to be less than 3, not going to be detected, right? So, or it's going to be so low that, all right, we're going to throw a number. It's going to be 10. Okay, great. That's not enough. Anything under, 25, 30 is not going to feel good for most women. That's why a lot of PMS symptoms and all of that happen. And I know. So further deep dive into that. But if you have had a hysterectomy, we need to confirm. Of course, I start with an estrogen level. I start with a follicle stimulating hormone, which is basically produced by the anterior pituitary gland in the brain. It signals your ovaries to do their job, tells them, hey, let's get producing these hormones. If your ovaries are no longer doing your job, your follicle stimulating hormone is going to be super high. So in that case, if that's high and your estrogen level is super low, I can go, great, you're in menopause. We know where you're at. Now I know why you're having all of these symptoms. So let's try to help that. Oh, I will add one more. Okay. We touched a little bit on low libido. It's a huge thing. I also check testosterone levels. I am a provider that does offer testosterone therapy to some of my patients in the right setting, because it is not FDA approved. So we have to tread very lightly with that. But that is something that I do offer, and I monitor very closely. I monitor your liver enzymes. I monitor your cholesterol levels while you're on testosterone therapy. I monitor your testosterone levels to make sure that they are not getting too high, because I don't want you losing your hair and growing a beard, among other things, for sure. So. Okay.
The question is, does testosterone have any impact on a woman's cognitive function?
Does testosterone have any impact on a woman's cognitive functioning? That is a great question, and we have about this much research on it. I will say that my patients who have been on testosterone therapy, which we use, again, symptomatic relief, low libido only, but I have had reports that their energy level increases drastically. They feel like they can recover better from whether it be exercise or even just waking up in the morning, like, hey, now I'm up and I'm moving and things feel fine. I have reports that their joint pain improves. I have reports that they're able to maintain lean muscle mass and a metabolic rate that seems a little bit more on par with what they're used to. Again, this is all anecdotal. I have no research to back that up. So whoever put that in the chat, great question. Thank you. Yet.
We don't know yet.
Yet. Yes, yet. Yeah.
What about patients that have other hormone-ish related things like PCOS or
Mhm.
PMOS now?
Yep.
How does that factor into HRT, and what are some things to kind of keep an eye out for as somebody beginning perimenopause with something like that?
Yes. So the question is, how does somebody with PMOS, I have to get used to saying that. It used to be called PCOS, polycystic ovarian syndrome. So that is a metabolic disorder, multifactorial. One of the issues is those patients already have hormone disruption. And in perimenopause in particular, your symptoms tend to be heightened because you live in a state of androgenism, blah, 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 too much testosterone, that kind of thing. And oftentimes you are estrogen dominant, meaning your estrogen level stays at a high level without your body properly clearing that estrogen. And the only way to truly detect that is your metabolite testing, which not everybody offers. It's considered a naturopathic test. We do offer it here. It's called Dutch testing. But it tells me a lot about how your body's actually breaking down your estrogen, because in those patients in particular, we see this excess estrogen that you just cannot clear. And so even though you might not have true estrogen deficiency symptoms, heightened estrogen, not enough estrogen, we oftentimes get the same symptoms. So it's figuring out, do we need to clear that estrogen, or do we need to help support and give you more estrogen, replace that estrogen? So it takes a lot of close monitoring is kind of the short end of that. Yeah. But you have me. Great. Any other questions? Yes, ma'am. I see it brewing.
Well,
I see it brewing.
you know me, I ask a lot of questions. I just wanted to go back to the prevention one.
Yeah, go for it.
Things that we can
Yes.
do. Just because I obviously work with a lot of women who are in that 20-year gap, and we often talk about what can we do. And so I just wanted to emphasize all the things that you can do on your own. You do have that power, or seize that power now that you have it. We also live in a current society where there is a lot of isolation, whether it's because your kids moved across the country, or your partner has passed away, or you've decided that you wanted to be independent and not join a facility, which you can actually create communities in those spaces. And so we can easily find ourselves declining only from social isolation. And so I just wanted to kind of double back on that, or double down on that, and say that, physical activity is monumental. Mobility is king. So even if it's just put your raincoat on and go down to the mailbox and come back, we start with baby steps, and then you build on that. We always encourage pelvic floor exercises, but we also encourage strengthening of lower body, strengthening upper body, really going to that gym. Look at your insurances will often have discounts at certain gyms, if not free membership. Utilize those, go in and bully them into giving you a trainer that's going to show you what to do when your favorite workout class is not happening. Talk to others, make friends, go to church, go to different community settings, volunteer. These are all things that inevitably will keep your mind moving, right? So I just wanted to stress that, so that you know that you're not powerless in this situation. There are things that you can take on. So.
Yep, absolutely.
Also, I follow a Mediterranean diet, but my snacks.
No, I'll call you out on that one. No, ma'am. No, ma'am. Everything in moderation. Everything in moderation. Okay, I'm not here. That's right.
Right.
Everything in moderation is okay, but don't take that the next step further. Yeah, but no, snacks are okay.
Okay.
I'm okay.
Snacks you have.
We eat a lot of cookies.
Yeah. Who's got the crumble app? Wait a second.
Somebody.
Oh, wait, I
It
do.
might be
So,
purchased by-
yeah. It's true. It's true. Yeah. Yeah. Every Monday, I'm like, this is going to be good. I'm going to come in, I'm sticking to my diet. And then Tuesday hits, and Courtney's like, I got these cookies.
Did you see what they have on the menu?
I know. Did you see this? Yeah. Mhm.
I'm
Yep.
so glad that.
No, it hasn't. It hasn't. Now I have the Crumble app. Thank you.
Yeah, you ordered that real quick the other day.
Oh, I sure did. I pulled that right up. Done. Yeah.
I've never even heard of it.
Oh, don't start. Don't start.
Courtney doesn't.
Pull her back.
Pull her back. Read it in. No, they are delightful though. They're closed on Sundays though. I'm very disappointed.
I was at the Springs at Janice Farm.
Oh yeah.
They make the best cookies in the whole world.
Oh, see?
Oh.
Yeah.
I
Okay,
gotta say,
Cookie,
like-
go for a walk.
Yeah, but that's what I swim. I mean, I go.
Perfect.
Yeah.
Swim, then have your cookie.
Good. You
See?
deserve that.
Moderation.
Well, that, eat a cookie. And not
Dark
every day.
chocolate?
My whole thing is not every day.
Yes.
Yeah.
Absolutely.
Yeah. If it's dark chocolate, it's even better.
Yeah, I don't care for.
Well, I mean, you can pretend. I'm trying.
Has to be.
Turn the light off while you're
It's too good for me.
See, oh, I like that. I love that. I love that. Turn the light off while you're eating it. I love it.
So I want to ask a question. What is AI? Is AI now having a bigger impact on discovery?
Oh,
I mean, the short answer is yes.
yeah.
The short answer is yes.
So do you all use AI to find out solutions or something?
We have a medical AI.
Yeah.
So we have like a chat GPT that is based in medical research that already exists.
Mhm.
So, I
It
mean,
helps us detect things faster.
it helps us. The way I see it is it helps us do that literature search
Yes.
much faster.
Yep.
I used to have to go to the library and ask the librarian, can I have all the magazines from this time? You know, now, right? Then we went to online. Everything was online. Now you can simply say, what do we know about dementia and HRT? And it's going to pull all the studies. It's going to summarize it for you, and it's going to give you all your references. And so when I think about my colleagues that are in academia, that's definitely what's happening. And we now have 2 platforms that are based in research. So to me, that's the role. And I think it's interesting because as a provider, I can read the response and say, oh, this is incomplete, right? I think that is where we have to be careful. If we rely on AI alone as the provider, we will not get the full picture.
Right.
Or as a patient, you won't get the full picture.
Yeah.
Like a tool.
It's
Yes.
a tool.
But you're using it frequently now, because I remember going to a PCP and said, is it okay for you? Right?
Yeah, a lot of them use it as a scribe. Yeah.
Well, AI is being used to make us more efficient in the clinic. And I could talk to you about why for like 5 hours.
Oh, yeah.
Because, you know, the way medicine, let me get off my soapbox, but essentially, we want to provide great care. But the cost of providing medicine is going up. And our providers are feeling that burnout. And so where AI has kind of taken a good stronghold is in documentation, which tends to be the thing that follows every provider home, which then leads to burnout.
Yeah.
So imagine, you know, when we were younger, we could see 10 patients and that would be enough to keep the lights on. Now, to keep those same lights on, you have to see 20 patients in one day. Not only that, but the population's growing. So what AI does is it takes the time it takes you to accurately document, it takes it from 2 extra hours a day to maybe 15 to 20 minutes.
Yeah.
It's unreal.
Yeah.
So I
It's
think
a game changer.
that's a big role. We also use AI to play some of the games that insurance likes to play, right? So AI can often detect, oh, this insurance company keeps denying this because you forgot to say that her eyes are blue. And so now we use AI to cut down on the back and forth between insurance.
Oh, that's great.
Yeah,
That's
it's
Yeah.
a real big
It
one.
is.
Our prior authorizations, we now have AI that tries to cut back on that. So it's useful, but again, it doesn't replace the people. It doesn't replace the people that are needed in order to make the clinic run. Speaking of which, bye, Fiona.
Okay. Oh, you're gonna take the long way?
She's enjoying her outdoor walk.
We talked her into being physically
She gonna be sweaty by the time she gets to her car. It's time. Yep, it's 6:30.
6:20.
Perfect. All right. Any other questions before we wrap it up, since we are out of time?
So is this online that we can?
Yep.
Yep.
So we are recording, and you're not on there, but
Yeah.
YouTube. It's going to be on our YouTube channel. It takes a couple days to
Do you know
upload.
the YouTube channels?
If you just look up Femme Flôr
On YouTube, you'll find it. Mhm.
I recommend adding the word clinic to the search as well.
Yeah. Oh.
Otherwise, you get a lot of like pelvic floor, like
Okay. Oh,
other
thank you.
information, but
see, good job. I was like, yeah, I knew it. I was like, she's gonna be sweating by the time she gets to her car. Bye.
Thank
Yep.
you, ladies.
Yes.
Thank you so much for coming.
Perfect. Looking forward to it. Good.
Lots of questions now.
Oh, I love it. Bring it on. I love it. I love it. Awesome. Yeah, thank you. Thank you guys at home. Appreciate it. All right.
That's good.
Just share.